Good evening and welcome to Doctors on Call. I'm Dr. Ruth Westra from the Department of Family Medicine and Community Health at the University of Minnesota Medical School Duluth, and I'm your host for tonight's program on women's health. We're glad to take your questions on menopause, hormone replacement therapy, abnormal bleeding, osteoporosis, and cancer in women. The success of this program is very dependent on you, the viewer, so please call in your questions and we'll do our best to address them. The telephone numbers for your questions can be found at the bottom of your screen. Our panelists this evening include Dr. Jolene Finken, an internal medicine specialist with St. Luke's Internal Medicine Associates, Dr. Emily Onello, a family physician at the Lake Superior Community Health Center and a faculty member at the University of Minnesota Medical School. Our medical students answering the phones tonight are Katie Howell from Faribault, Minnesota, Abby Sauer from Forest Lake, Minnesota, and Brittany Vapland from Kellogg, Minnesota. And now on to tonight's program on women's health. So we'll probably start with a few general questions while we're waiting for the callers to call in some questions. And one of the questions, we'll start with you, Dr. Onello, is, we talk a lot about women's health and gynecological issues, but what's more common for women as far as diseases that we should worry about?
I think that's a really interesting question because when I see adult women in my practice, there is often a lot of concern and focus on, of course, screening for gynecologic cancers such as breast cancer and uterine cancer. But it is important to remind ourselves that the number one cause of illness and death in the United States for women is cardiovascular disease, which generally would include things like heart attacks, heart failure, and strokes. So focusing on reducing risk factors for that, I think, is the most important health issue that a woman could look at if you're trying to assess your overall health.
Mm-hmm. And we've had a lot of changes in some of our gynecological preventative health. So Dr. Finken, maybe talk a little bit about mammogram screening and changes that we have just recently.
Okay, and that is always something that is subject to change. There are 3 different recommendations from 3 different bodies. Some of them are very structured in a way that they would recommend mammograms every year after age 40. Another body says we shouldn't even start until after age 50 and then every other year, and then there's the middle of the road. So, I think it is a lot depends on your risk factors and your comfort with doing the mammograms, because there are risks of false positives and overscreening and finding things that might not be harmful, unnecessary biopsies. So I'm personally, I still do at least every other year in the 4th decade and then every year after age 50. But I think it would vary depending on the physician that you ask.
Well, thank you. Dr. Melissa Stank has also joined us, and she's from St. Luke's OB-GYN, so welcome, Melissa. So Dr. Stank, let's talk a little bit about the pap smear screenings and just some recent changes that have also happened in pap smear screenings.
Sure. The pap smear screening has evolved over the years, and currently we really don't recommend pap smears till the age of 21. After that, every 3 years until the age of 65, unless there's an abnormal pap smear. And if there's an abnormal pap smear, we do some testing, and oftentimes we increase how frequently we have to do pap smears.
Oh, that's very helpful. Well, Dr. Finken, tell us a little bit about smoking and what our recommendations are for women.
Well, a complete abstinence. It's the single most important thing you can do. That combined with exercise. Some people would say obesity and being, well above your ideal body weight is just as harmful, but that is the number one thing to, for preventable cause of death is, it's not just the cancers, it's the cardiovascular disease. So that is an absolute must, just complete cessation. And it's hard because it's not just a physical addiction, it's very psychologic, and there are things that we can use, medications, there's Zyban and Chantix, but all the studies say that a drug alone, of course, is not going to be 100% effective. A lot of this is support groups, and that will definitely improve your chance of success.
Dr. Onello, DEXA scans are something that a lot of women have or recommended as they get older for worries of osteoporosis. Are there any recommendations as far as when we would start ordering those?
You know, that's a very interesting question, because I think in the course of my practice it's evolved a little bit. When that first came to bear, I think I was using them quite frequently. But I believe the current guidelines generally, and my colleagues can correct me on this, I think we suggest beginning a baseline DEXA scan at age 65, which for many of my patients often is surprisingly late. I do think, as with many of the things we discussed this evening, there are exceptions to that. If your physician or your provider identifies that you may be at high risk for some other reason, for thinning of the bones or osteopenia or even osteoporosis where the bones are very brittle, that you may want to talk that over with them. There are, of course, exceptions to that general recommendation, but I believe it's age 65 that you would talk to your doctor about having that test done.
So smoking might be one of the things that puts you higher at risk of osteoporosis?
That's right. And some medical conditions, or even the treatment of those conditions, such as using certain seizure medications or having thyroid disturbances, can also affect bone strength.
Well, Dr. Stank, I have a caller from Duluth asking about bladder cancer in women. And how common is bladder cancer in women? And how would we, what kind of symptoms would a woman present with?
Bladder cancer isn't a common cancer. There are risk factors associated with bladder cancer, like smoking and working around certain chemicals. A lot of times women don't have any symptoms. Sometimes we find a little bit of blood on their urine if we have to collect a urinalysis for some other reason, or a urine sample. So oftentimes we really don't find any symptoms, but we watch very closely that if we do find blood on a urine sample, and it is persistent, that we do send women for further diagnostic testing at that point. Does anybody have anything to add about bladder cancer?
Yeah, I think that's a great point, in that it's not generally, to my knowledge, one of the cancers we would screen for or look for. So as you said, it's very important if someone has even microscopic blood in their urine specimen that gets attended to.
As well as probably kidney cancer.
right.
We check the urines for that as well. Probably Dr. Onello asking about having had a hysterectomy, but the cervix was not removed, and the patient is asking if caller from Duluth if they still need pap smears.
That's a good question.
Yeah.
My understanding is that historically that was done more than it's done today. I think the answer, and my colleagues can correct me, but I think the answer is yes, because they still have a cervix up until the guidelines that Dr. Stank discussed. Yes, I think they would still need a pap smear.
If the cervix is maintained, we do recommend the same cervical cancer screening guidelines we would if they had never had a hysterectomy. And that's every 3 years until about the age of 65, unless there's an abnormality.
Pretty much the same. So Dr. Finken, a caller from Duluth, is asking about bruising easily. And the blood work has been normal. Is there anything else that the patient should be worried about?
And it is very common, bruising. As we get older, the tissues become more thin, our collagen becomes weaker. Some people are very sensitive, and even a baby aspirin a day can cause some significant bruising. But I think the important thing is to have those initial tests and to check the platelets and make sure the blood cells are normal. Some people say there's a vitamin C deficiency because that adds to collagen strength, but that is a common thing, and it depends on the age too. Von Willebrand's disease is one of those things that often isn't diagnosed, and that is something your doctor can test for. So I think it's just something you need to talk to your doctor about and have the appropriate blood work. But it does become much more common. I mean, it's not a serious thing. It's just more common as people get older.
Kind of a segue from that is like aspirin. I mean, do we recommend aspirin? Dr. Onello, I'll kick off with you first.
Yes, I think as with mammograms, sometimes, you know, as a physician, you sort of have to follow the literature a little bit. It does change as studies come out. Generally, I think the feeling, using aspirin in a preventative fashion, so we're not talking about for headaches or for sore muscles, but if the intention is to prevent problems, generally, I think the guidelines would suggest, unless you have a risk factor for blood vessel disease such as diabetes, we generally are not counseling younger adults to take aspirin preventatively. That changes at certain ages for men and women, and that's what's often changing in the literature. But generally, I think it would be more recommended for older folks or at higher, or people who are at higher risk.
Yeah, typically over, and again, based on the studies, a bit of a moving target. 65 and older is when we really start talking about aspirin for prevention of heart attack and stroke. Before that, you really have to calculate risk factors for heart disease and stroke, and then you have to really discuss the risks and benefits of, the bleeding risks of aspirin or aggravation of hypertension, ulcer. People who have had ulcers, don't tolerate aspirin daily, or so you really have to individualize therapy. But it's usually around age 65 that you really start talking about that, unless there are other things. Now this is just primary prevention, meaning they haven't had a heart attack or a stroke. Obviously, if you've already had an event, then you'd be on a baby aspirin a day. But diabetes, diabetics, usually it is recommended that they're on an aspirin a day as well.
Sure. Well, Dr. Stank, I know this would come up as estrogen and postmenopausal. So the use of estrogen in women postmenopausal and potential risks?
Mm-hmm. This has been a long controversy. And again, following the literatures, it changes all the time. But the current literature suggests that there are small risks associated with hormone replacement therapy. Those risks may be a slight increased risk of breast cancer, 6 women per 10,000 women. An increased risk of stroke, possible heart attack, and blood clot, again, 6 per 10,000 women. But there are benefits associated with hormone replacement therapy. Some women really need it for the quality of their life. Some women have hot flashes and they find it hard to maintain a normal lifestyle because they're up all night, unable to sleep. Some women feel that it helps them emotionally. Most women stop having hot flashes approximately 5 years after menopause, but there are a small group of women who have hot flashes for the rest of their lives. So some women do stay on hormone replacement therapy for the rest of their lives. So it's a benefit versus risk to the woman who needs it. We do prescribe it, and we continue to prescribe it because, again, it has a lot of benefits to women. It also decreases the risk of osteoporosis. Mm-hmm. And there's also local estrogen that's placed vaginally that helps with something called atrophic vaginitis, where women may experience burning and itching because of not having estrogen in that area. And that estrogen, very little is absorbed, and it is very safe. And it helps so that women can maintain sexual activity throughout their lifespan. The only thing I was going to say about estrogen also, or the hormone replacement therapy also, is that if a woman still has her uterus, she hasn't had a hysterectomy, we do have to add progesterone to that regimen just to prevent endometrial cancer. But with estrogen and progesterone together, it actually decreases the risk of endometrial cancer.
Oh, that's very helpful. Dr. Finken, I have a caller from Cloquet asking about congestive heart failure, which actually are both men and women, because some women obviously live longer, seems to be a common diagnosis as we age. Can you talk just a little bit about that and the swelling that occurs with congestive heart failure?
Okay. Well, congestive heart failure, it's never a diagnosis in itself. It's the heart is not working well, moving the blood forward, and it always has a cause. Either it's high blood pressure or maybe heart attacks. There is an underlying cause. And so some of the symptoms the main symptom is shortness of breath. And you can have some swelling in the legs as well. So the best way to protect the heart is to just go in for those yearly exams and make sure the blood pressure is well controlled and control risk factors for heart disease, prevent the heart attack. Because it is really the result of something else, and it's a very preventable, modifiable thing usually.
And Dr. Onello, sometimes it's hard to know if you're seeing blood, if it's coming from the urine or the vaginal area, and what would we be concerned about if we didn't know and it wasn't from the urine in someone who had stopped having periods?
Okay, I'm glad you mentioned that at the end of the question because clearly the age of the patient would impact how I approached it. I don't think we've mentioned it yet in the discussion today, but the definition of menopause is no menstrual period for a year. So assuming this patient you're talking about has not had any menstrual cycles for over 12 months, we would consider any blood or even light spotting abnormal and worthy of further investigation. It can be tricky sometimes to identify the source of the bleeding, but I think if the patient is concerned, obviously either source would be worth a trip to the doctor, and it would be important not to delay that. And the concern, many things could cause that bleeding, but the concern I would have as a family physician is, could this be a clue that there may be an abnormality within the uterus or even possibly a uterine cancer?
Mm-hmm. So maybe a biopsy or something might be performed?
Precisely. Certainly an examination and discussion with your physician, perhaps an ultrasound of the pelvic organs, and likely a biopsy of the inside of the uterus. Correct?
Thank you.
Yeah.
And Dr. Stank, a caller is asking about, from Cloquet again, we have a lot from Cloquet tonight, UTI in older women. How can it be controlled? It seems to be recurrent for some people.
Recurrent bladder infections or UTIs in older women can be caused from a number of things. One common cause is if this woman isn't emptying her bladder completely, and there's some bladder some urine still in her bladder, which can cause infection. And that's common with people with pelvic prolapse, meaning that their bladders kind of fall down into their vagina, and their uterus and cervix may fall kind of down and out in their vagina. So again, I'd recommend seeing a physician to rule that out. Another common reason for recurrent bladder infections is what we had talked about before, atrophic vaginitis. And oftentimes local estrogen that's placed vaginally can help keep the vagina a healthier area and can also prevent recurrent bladder infections.
Dr. Finken, a caller from Duluth about heart attacks. And do women have different symptoms than men?
They always talk about the atypical presentation of heart disease in women. And so typically you think of the heart attack as the left-sided chest pain radiating down the arm into the jaw. But for women it can just be something as subtle as, I just feel a little more winded when I'm walking up the stairs or to the mailbox, or I just feel some tension or tightness through the back of my neck, some jaw discomfort. I mean, there can be different symptoms. They typically often follow the same setting or context, when you're exerting yourself. It's not always going to be the crushing chest pain. Angina or heart attack can present different. Sometimes it's something as subtle as nausea or sweats. So it can be very tricky. If you're not certain, it's so easy just to go to the emergency room and get checked out and get an EKG and get a blood test, and because it's not as straightforward in women a lot of times.
Better to be evaluated and to make sure that you've contacted your doctor. Dr. O'Neill, a caller from Duluth asking about thyroid, hypothyroidism, and is it more common in someone over their 70s?
And you said hypo. Which hypo indicates insufficient or not enough thyroid hormone, and hyper generally means you have too much of something. So hypothyroidism, I am aware that it's more common in women generally, though both genders can have problems with thyroid. The question I guess the caller is asking, is it more common as we get older? And I can't say that I know for sure that that's true. I don't have that impression necessarily. More just that it's more common in women. I don't know the specific numbers, but I think it can be tricky as we get older because many of the symptoms of hypothyroidism can also be some of the symptoms of aging, such as drier skin, constipation, fatigue. And so I think I order many thyroid tests on some of my senior patients because I want to rule it out. But I don't rightly know if it truly is more common as we get older, but many of the symptoms can be experienced.
Yeah, it does seem to be a test that we commonly order when we see women coming in for their physical exams. Dr. Finken, do you have any?
Yeah, I know for a time there was no recommendation to screen, and then I think they said over the age of 60 a one-time screening. But again, the symptoms, whether it's fatigue or weight gain, I mean, the symptoms are so common that most women end up with a screening thyroid test for a reason rather than screening, which is really semantics. I think to always have a high index of suspicion and just ask your doctor about it, because a lot of the symptoms that can come as we get older often can also be consistent with hypothyroidism. So I think it's worth getting, in every woman at least once.
I agree, and just to add to what you already said, the test is fairly simple. It's not even a fasting test. It's a simple blood test. It can be added to routine lab draws. So it's easy to check.
And what's the name of the test?
The thyroid stimulating hormone is generally used. There are some other thyroid tests that give you more detail, but that's the one I would typically order first, abbreviated TSH.
That's very helpful. Dr. Stank, there's a caller from Evelyn asking about vitamin D. This is a common thing that we are obviously checking now. Are there certain levels that we should check or certain times of the year that we should check for a vitamin D level?
I don't know the exact level we look at. I seldom check it. I'm working with usually younger patients. Vitamin D deficiency is very common, especially in this area of the country where we don't get a lot of sunlight. And for a lot of the year, even when we are out in the sun, we're bundled up. And it's also common in southern areas of the country because of sunscreen. When we wear sunscreen, we don't get the absorption. So do you want to comment on when?
It's very common, and we used to be able to check screening vitamin D, but insurances often don't cover it anymore. But when we were, very few people are high in the normal range. Most people are low normal or insufficient. So at a minimum, I recommend 1,000 a day. For most people, I just say 2,000 a day. And the Institute of Medicine recently said, you know, we could cut back and recommend only 800, but it's just not what I'm seeing in my clinic. Whenever I check vitamin D levels, they're low, and even when people supplement, they're still low. So I say 2,000 every day.
Several questions about osteoporosis, so let me start with a few of these. I will ask about some medications. One of them is, which we commonly use, is like like Flomax, Dr. O'Nella. It's like once a week we utilize that medication. Once we've started a patient on medication, then how do we follow them up?
Okay, and just to clarify, I think you said Flomax, but I think you mean Fosfamax,
yes,
right?
Absolutely.
All these
They've
names
got the
sound the
one,
same.
So
okay,
I got a good one.
But they can be similar. The question was, how do we follow that up? That is a great question, and as Dr. Finken said earlier, sometimes these guidelines are moving targets. But the notion would be using that test you mentioned earlier, the DEXA scan, which is essentially a series of x-rays that compare your bone appearance and density to some normalized standards. And then the test would be to repeat the DEXA scan after 2 or 3 years of therapy. There certainly are more intricate metabolic tests. I believe there are even urine tests that you can get a peek at how well the bones are sort of holding their integrity. I don't really use those very commonly anymore. So generally what it would mean is when you come back to your doctor several years after starting treatment, they would just repeat the bone imaging and just simply see how your bones have held up. Is the treatment effective? Has it made a difference?
Sure. Dr. Stank, this is a good question about pessaries and probably, you know, prolapse, how we can treat it. It's a caller from Duluth.
What specific question?
So the pros and cons of using a pessary.
Oh, a pessary. When people present with prolapse, and again, prolapse is when the bladder can kind of fall out of the vagina, the rectum can kind of come and fall out and create pressure, and the cervix and uterus or the vagina can just kind of fall out. The symptoms of prolapse are typically, sometimes women have trouble completely emptying their bladder. They can feel pelvic pressure, sometimes pain, pelvic pain, back pain. Back pain's common, but it's more of an achy pressure pain that these women experience. And sometimes they even have where they have it fallen out where it actually rubs and causes ulcerations or sores. And there are 3 options. If, even though someone has prolapse, it's not bothering them, we really don't have to treat it at all. Another option is a pessary, which is a device that actually kind of sits in the vagina and holds everything up. It works very well. People do have to come in the office anywhere from once a month to every 3 months to have it taken out, cleaned, and then changed. And there are some women who can take out their pessary on their own and even come to my office just once every 6 months to be evaluated. And then some women choose to have a surgical correction of their pelvic prolapse. And it really depends on what the best option is for each individual woman. But I recommend either one of the 3 in women that do present to my office with pelvic prolapse.
Very good, thank you. This is a great question probably to end because we don't have too much more time, but Dr. Finken, it's a question about if your general body shape has an effect on your health or your overall health.
Yeah, they say those apple-shaped people, the adipose tissue around the abdomen is more indicative of cardiovascular disease and diabetes and metabolic problems. So that's the party line on that. So rather than the pear-shaped people, and it's probably got something to do with the adipose tissue is not just fat cells. I mean, it's metabolically active, and it has to do with the metabolism of glucose and the predisposition for diabetes.
And really can't change that. It is what it is.
Genes.
So. Well, thank you all very much. I want to thank our panelists, Dr. Jolene Finken, Dr. Emily Onello, and Dr. Melissa Stank, and our medical students, Katie Howell, Abby Sauer, and Brittany Vaplin. Please join Dr. Ray Christensen for a program next week on men's health, when his panelists will be Dr. Mitch Cardwell, Dr. Dave Hutchinson, and Dr. Paul Tonkin. Good night.